Welcome to the Cannabis Pharmacology Module, Section 6, Cannabis Addiction, Withdrawal, and Cannabis Use Disorder. The lifetime risk of dependence for cannabis is around 9%, similar to caffeine and significantly less than alcohol, cocaine, heroin, or nicotine. The highest risk of cannabis dependence is seen in people with poor academic achievement, deviant or rebellious behavior in childhood and adolescence, poor parental relationships, and a family history of drug and alcohol problems, indicating that lifestyle factors play an important role in the development of addiction to cannabis. The lethal dose of cannabis has yet to be determined and is estimated at a level far past the possibility of human consumption. A margin of exposure study, which measures the ratio between toxic threshold and estimated human intake, determined cannabis had an MOE of greater than 10,000, indicating the toxic threshold of cannabis consumption is more than 10,000 times the normal human dose. Alcohol, nicotine, cocaine, and heroin all fell into the high-risk category with a margin of exposure of less than 10 for comparison. Thus far, 0 deaths have been confirmed as being caused by cannabis overdose. But this should not be confused with the fact that significant drug interactions and cardiac side effects do still exist and pose a threat to patients. Cannabis withdrawal symptoms are usually seen when heavy users of high THC cannabis stopped cannabis abruptly and include anger or aggression, decreased appetite, irritability, anxiety, and insomnia. None of the withdrawal symptoms of cannabis are life-threatening as compared with alcohol or benzodiazepine withdrawal. Symptoms of cannabis withdrawal appear 1 to 2 days after cessation and typically resolve in 1 to 2 weeks without medical intervention. It is important to note that cannabis withdrawal symptoms are typically not seen upon abrupt cannabis discontinuation in patients using cannabis for medical purposes. In studies of nabiximols, a 1-to-1 ratio of THC to CBD administered sublingually, tolerance did not occur over time, abrupt withdrawal did not result in a formal withdrawal syndrome, and nabiximols has not been abused or diverted to any degree in more than 30,000 patient years of recorded usage. Cannabis use disorder is estimated as occurring in about 8% of the population of cannabis users and is a problematic pattern of cannabis use leading to clinically significant impairment or distress, as manifested by at least 2 of the following symptoms occurring within a 12-month period. 1. Cannabis is often taken in larger amounts or over a longer period than was intended. 2. There is a persistent desire or unsuccessful effort to cut down or control cannabis use. 3. A great deal of time is spent in activities necessary to obtain cannabis, use cannabis, or recover from its effects. 4. Craving or a strong desire or urge to use cannabis. 5. Recurrent cannabis use results in failure to fulfill role obligations at work, school, or home. 6. Continued cannabis use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of cannabis. 7. Important social, occupational, or recreational activities are given up or reduced because of cannabis use. 8. Recurrent cannabis use in situations in which it is physically hazardous. 9. Cannabis use continues despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by cannabis. 10. Tolerance, as defined by either a need for markedly increased cannabis to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of the substance. And 11. Withdrawal, as manifested by either the characteristic withdrawal syndrome for cannabis or cannabis is taken to relieve or avoid withdrawal symptoms. Cannabis use disorder is qualified as mild if 2 to 3 of these symptoms are present, moderate if 4 to 5 of these symptoms are present, and severe if 6 or more of these symptoms are present. The development of cannabis use disorder can be mitigated with proper patient care. Patients with a history of substance abuse, particularly when associated with compulsive use disorder, should be advised against the use of cannabis medication. Patients using more than 30 mg per day of THC are more likely to be at risk for cannabis use disorder, as tolerance occurs rapidly with higher doses and frequent use. Patients should be counseled against chasing the high, and they should also be advised if they are on larger doses of THC that they should take periodic 48-hour breaks, as this will allow for tolerance levels to reset and for the patient to resume therapy with a smaller effective dose. Patients should also be counseled to try a CBD-rich dosing ratio as an alternative therapy to mitigate the tolerance and chasing high that happens with doses of more than 30 mg per day of THC. Cannabis therapies containing greater amounts of CBD pose a significantly reduced risk for the development of cannabis use disorder. In summary, cannabinoids are highly lipophilic and protein-bound in the body, which affects their pharmacokinetic profile. Unlike traditional pharmaceuticals, cannabis has wide variability in patient effects, so the best dosing approach is to start low and titrate slowly over time. Cannabis dosage forms have varying onset and duration of action, which should be assessed along with patient symptoms and desired outcomes when choosing the best form of administration. Cannabis side effects are largely determined by THC and can be mitigated through low dosing and slow titration of the medication. Patients should be evaluated for any contraindications or precautions to cannabis use prior to the initiation of cannabis therapy, as well as for any potential drug-drug interactions. Several genetic factors may influence how patients respond to cannabis and will play an influential role in future product development, testing, and diagnostic procedures. Cannabis use disorder can be mitigated with proper patient evaluation, dosing, and titration, but practitioners should always remain aware of the signs and symptoms of the development of cannabis use disorder. This concludes the Cannabis Pharmacology Learning Module. Thank you for joining us.